Hello everyone. In today's session, we are going to discuss about viral hepatitis. It is a continuation to the topic epidemiology of communicable diseases. The objectives of this session are to understand the viral hepatitis and the classification of viral hepatitis, to recognize the epidemiological determinants of viral hepatitis, understand the mode of transmission, risk factors of the different serotypes. Also, we would appreciate the pathophysiology, clinical features, diagnosis, prognosis of the different serotypes, and also to comprehend the measures of prevention and management of different serotypes of viral hepatitis. So, what are the things we are going to see? That is, 1. Epidemiological determinants, mode of transmission, risk factor, pathophysiology, clinical feature, diagnosis, prevention, and management. Viral hepatitis. Viral hepatitis is a systemic disease where there is a primary inflammation of the liver. So by the term hepatitis itself, you know that itis is a Latin suffix which stands for the inflammation of the liver. Since it is a viral infection, it is caused by the viruses. Viral hepatitis is the inflammation of the liver. The most common cause of the viral hepatitis are 5 unrelated hepatotropic viruses. So these 5 viruses are unrelated hepatotropic viruses and they are categorized as hepatitis A virus, hepatitis B virus, hepatitis C virus, D virus, and hepatitis E virus. In addition to the nominal hepatitis viruses, those 5 different unrelated hepatotropic viruses which we mentioned, the other viruses which are causing the inflammation of the liver are the herpes simplex, cytomegalovirus, Epstein-Barr virus, and yellow virus. So what is the gist of this slide? What did we understand? What is viral hepatitis? Viral hepatitis is the systemic disease where there is inflammation of the liver which is caused by 5 serotypes. In addition to the 5 serotypes, we have other viruses like herpes simplex, cytomegalovirus, and so on which are causing the inflammation of the liver. There are certain clinical terms which are given here which you need to be aware of before getting into the topic. You need to know what are these terms. Hepatitis. What do you mean by hepatitis? We've discussed it. Hepatitis is inflammation of liver. Then comes the inflammation of the liver can be acute viral hepatitis or a chronic viral hepatitis. Acute viral hepatitis, the term acute itself indicates that the symptoms will start sudden and then there is a rapid progression and they last for a short duration. So it shows that it is lasting for less than 6 months, then it is considered to be acute. Chronic hepatitis, when the inflammation of the liver is for more than 6 months. This is less than 6 months and chronic is more than 6 months. Then comes fulminant hepatitis. Fulminant. What does the word fulminant mean? It means acute or sudden plus very severe. Okay, if it is onset is very sudden and very severe, then it is fulminant. Fulminant hepatitis where there is severe impairment of the hepatic functions. So the functions of the liver, there is severe impairment, there is a severe problem, in the hepatic function, or there is a severe necrosis of the hepatocytes. Necrosis is the death of the hepatocytes. Hepatocytes are the cells of the liver. So there is a severe death of the hepatocytes in the absence of a pre-existing liver disease. Now, if a person is suffering from some liver disease and there is a severe necrosis of the hepatocytes, then it makes sense. Okay, it is a chronic condition. But here, fulminant, what happens? There is no presence of any pre-existing liver disease. In spite of the absence of a chronic infection, there is a very severe necrosis of the hepatocytes and there is impairment of the function of the liver. Clear? That is all about the fulminant hepatitis. And then we will see what is cirrhosis. Okay, what is cirrhosis? When there is a replacement of this liver tissue with the scar tissue. The scar tissue is nothing but the fibrosed tissue. So whenever there is replacement of a normal tissue with that of a fibrosed one, it is known as cirrhosis. These changes will also lead to the loss of liver function. Obviously, if there is a scar tissue present, there is a fibrosis occurring there, the liver cannot function properly, the hepatocytes are affected, it is leading to the loss of liver function. And then comes acute hepatic failure. The appearance of severe complications rapidly after the first signs of liver disease. The first signs of liver disease could be jaundice. So, there is severe complications which are occurring. Soon after the first signs are appearing, it shows that liver has sustained a very severe damage. So, we see that, what are they saying? There is appearance of severe complications and these complications have occurred soon after the appearance of first signs of liver disease. Okay, soon after jaundice, if severe complications are seen, it indicates that liver has sustained a damage. 80 to 90% of the function of the liver cells is impaired. Massive hepatic necrosis with impaired consciousness within 8 weeks of onset of illness. Just within 8 weeks, the patient becomes unconscious, goes into loss of consciousness, or the impaired consciousness is seen in these patients, then it is considered to be an acute hepatic failure. Is it clear? How will you diagnose in your practice or in your clinics? How would you diagnose a patient to be having as an acute hepatic failure if he presents to you with the simple symptoms, first signs of a liver disease like jaundice, and then he is having a very severe complication and there's loss of liver function by 80 to 90%, severe massive hepatic necrosis have occurred and the patient is having impaired consciousness within 8 weeks of onset of illness, then he is considered as acute hepatic failure. Moving further to the types of viral hepatitis. We have hepatitis A, B, C, D and E as discussed earlier. So let us just quickly go through this chart, and before going in detail about each of these viral hepatitis, we will keep revising this chart so that we are very familiar with the differences between each of them, because all of these are unrelated to each other and there is a difference present. To begin with, hepatitis A, it is caused by single stranded RNA which is having no envelope. Okay, the RNA is single stranded with no envelope present. Route of transmission is fecal-oral. The age affected are mostly children. We have seen many cases coming to our hospitals that children are mostly affected with hepatitis A more commonly. Also in conjugation with hepatitis E as well, co-infection could also be there along with hepatitis A, but most common we see hepatitis A children being affected. The carrier state is nil. Incubation period will be 10 to 50 days. Chronic infection is not found. It is an acute disease, okay? Children, acute. That is how you can remember. Children in acute hepatitis A. And then the specific prophylaxis will be immunoglobulin and vaccine. Then let's discuss about hepatitis B. Hepatitis B is a DNA virus, okay? BD. Hepatitis B is a DNA virus. It is enveloped. Okay, it is enveloped. The route of transmission is parenteral, vertical, sexual transmission, etc. And then the age affected, it can affect any age, and the carrier state is present in it. Incubation period is 30 to 180 days. Chronic infection is seen. Hepatitis A is acute, whereas chronic infection is present in cases of hepatitis B, and the specific prophylaxis will be immunoglobulin and vaccine. All of this will be discussed in detail. For now, let us just have a gist about it. Then comes hepatitis C. Hepatitis C, what do we see? Again, it is an RNA virus. It is enveloped. Again, let's draw the same diagram for it. It is a single-stranded RNA. It is enveloped. Only A is not enveloped. Next, we will see. Then comes the route of transmission is parenteral. Age affecting is the adults. Carrier state is present. Incubation period is 2 weeks to 6 months. And the chronic infection again is a yes. Specific prophylaxis, we have no treatment, no prophylaxis for hepatitis C. Then we have hepatitis D. It is a single stranded RNA and it is enveloped. Okay, it is enveloped with hepatitis B virus. So, hepatitis B virus occurs most commonly with hepatitis D virus. It can be a co-infection or it can present in the form of a super added infection, and hepatitis D requires the hepatitis B for its replication. Okay, hepatitis D, the envelope is hepatitis B virus. And then route of transmission is parenteral. It can occur at any age. The carrier state is nil, and the incubation period is 2 to 12 weeks. Chronic infection is present. Specific prophylaxis will be hepatitis B vaccine. See, we see here it is associated with hepatitis B vaccine. So the prophylaxis is also hepatitis B vaccine. Okay, then comes hepatitis E. So there is some similarity between A and E, that is both of these are acute infection and the transmission is fecal-oral. Okay, this is the similarity. A and E, fecal-oral, and it is acute, and A is also acute, E is also acute. Specific prophylaxis is nil. Carrier state is nil. It usually affects the young adults, and incubation period is 2 to 9 weeks. So now I will be highlighting only the uncommon ones. Okay, hepatitis A is enveloped. It is acute, fecal-oral, and chronic infection is not there, not present, affects the children. Then comes hepatitis E. It has no envelope. It is an RNA with no envelope. Mode of transmission is fecal-oral. It is not an acute infection. It is not a chronic infection. It is an acute infection. A and E are acute infections. Is it clear? Now, let us start to discuss in detail about the hepatitis A. From the chart, we have some idea. To some extent, we can figure out what is the causative agent, what is the mode of transmission. So we will have a better clarity in detail about it. We will discuss about the prevention, the treatment aspect, the prophylaxis, about the vaccine, and incubation period, how it gets transmitted, who are the people which are under the high risk group for hepatitis A. All of this will be discussed. Let us start with hepatitis A. Hepatitis A was formerly known as infectious hepatitis. Hepatitis A was known as infectious hepatitis or epidemic jaundice. It is an acute infectious disease which is caused by hepatitis A virus. Is it clear? It is caused by hepatitis A virus. Okay. Then hepatitis A is the most common type of viral hepatitis. Often it is seen in cases of epidemics. So hepatitis A has gained a lot of popularity in causing epidemics. Okay, it has important role in causing epidemics. The disease is benign with a complete recovery in several weeks. So, if a child is diagnosed with hepatitis, there is a chance that hepatitis A, okay, hepatitis A, there is a high chance that 99% of the cases there is recovery seen. Only 0.4% goes into the fatality. Okay, the disease is benign. There is a complete recovery in several weeks. So, it is acting as a self-limiting disease. The exact incidence of disease is difficult to estimate because there is a high proportion of asymptomatic cases. Today, we do not know the exact new cases which are occurring. The incidence is difficult to figure out because most of the cases are asymptomatic. Large proportion are asymptomatic cases. However, based upon the ongoing reassessment of the global burden of hepatitis A, World Health Organization has suggested a value of about 1.4 million cases which are occurring every year worldwide. So what is the statistical data which we have got? That according to the World Health Organization, it states that 1.4 million cases are occurring every year. So hepatitis A, 1.4 million cases are occurring worldwide. Is this slide clear? Now we move further to the geographical distribution of hepatitis A. Geographical areas can be categorized as having high, intermediate, low, very low levels of hepatitis A infection. Areas with high levels of infection in the developing countries who are having a poor sanitary condition, poor hygiene practice. Most children, 90% of the children have been affected with hepatitis A virus before the age of 10 years. Is it clear? High infection is seen in cases of developing countries. Let us write it down here. High in cases of developing countries, the hepatitis A is very high because of the poor sanitary conditions and poor hygiene practice. Whereas areas with the intermediate levels of infection, in the developing countries and the countries with transitional economies and regions where the sanitary conditions are quite variable, children will escape the infection in the early childhood. Ironically, we see that these improved economic and sanitary conditions is leading to the higher susceptibility in the older age groups, and the older age groups are having a higher disease rate because the infection is occurring in adolescents and adults, and outbreaks are seen in cases of adolescents and adults in cases of intermediate levels of infection. So these areas which are having intermediate levels of infection, here there is variable sanitary condition, variable hygiene practices, so the children are escaping and large number of cases are seen in cases of adults. Then comes areas with low and very low levels of infection. It is in cases of developed countries. Is it clear? High in developing countries, children are affected, and again intermediate is also in cases of developing countries, and here they have variable sanitary conditions leading to their incidence in cases of adults. This is commonly affecting the children, and low and very low is seen in cases of developed. The developed countries will have a good sanitary conditions, good hygiene conditions, so the infection rate will obviously be low in these countries. Is it clear? The geographical distribution. Now we move further to the epidemiological determinants of hepatitis A. The agent factor is hepatitis A virus. Is it clear? What is the agent factor? It is the hepatitis A virus. It is an enterovirus of Picornaviridae family. It is multiplying only in the hepatocytes. So where does the hepatitis A virus multiplies? The hepatitis A virus multiplies mainly in the hepatocytes. Okay? It multiplies mainly in the hepatocytes. It is a non-enveloped virus. So we saw that it is a single-stranded RNA and it is having no envelope. So it is non-enveloped and measures about 27 nanometer. The virus is fairly resistant to heat and chemicals. The HAV virus is resistant to heat. It is also resistant to chemicals. It withstands the heating to 60 degrees Celsius for 1 hour, and it is not usually affected by chlorine in the doses which are usually employed for the purpose of chlorination. So the hepatitis A virus is not affected by the chlorine dose which is normally used. The formalin is stated to be effective disinfectant against the HAV. The virus is inactivated by the ultraviolet rays and by boiling for 5 minutes or by autoclaving. Is it clear about the resistance? It is very resistant to heat, it is resistant to chlorination, so formalin is used instead, and ultraviolet rays will inactivate the virus by boiling for 5 minutes or by autoclaving. Then comes the reservoir of infection. The human cases are the only reservoir of infection. Then we see the period of infectivity. The risk of transmitting HAV is greatest from 2 weeks before to 1 week after the onset of jaundice. So we see a patient has developed with jaundice and he is infective. The period of infectivity, how long the patient is infective to others, is 2 weeks before, 2 weeks before and 1 week, 2 weeks before and 1 week after the onset of jaundice. Moving further to the infective material. The infective material is mainly the man's feces. Then comes the virus excretion. HAV is excreted in the feces for about 2 weeks before and after 2 weeks thereafter the onset of jaundice. Okay, it is infective for 2 weeks before and 1 week after the onset of jaundice, and the virus excretion is 2 weeks before and 2 weeks after the onset of jaundice. Moving further to the host factors. Age. Infection with HIV is more frequently found among the children compared to the adults. However, people from all the ages may also be infected if they are susceptible. Then we see the sex. Both the sexes are equally susceptible to hepatitis A virus. Immunity after the attack probably will last for a lifelong. Moving further to the environmental factors. Cases may occur throughout the year. In India, the disease are associated mainly with the periods of heavy rainfall, and during that period, the poor sanitation, the overcrowding is favoring the spread of the infection, giving rise to the waterborne and foodborne epidemics. So in India, because it is still a developing countries, and there is a poor sanitation and overcrowding, all of this is favoring to the waterborne and foodborne epidemics. Okay, then we move further to the incubation period. Incubation period, as we saw in the chart, is 10 to 50 days, usually 14 to 28 days. There is no carrier state for hepatitis A. Okay, it is in the children and there is no carrier state. It is seen in children and there is nil carrier state for hepatitis A. It is an acute infection. It is caused by HAV virus. Moving further to the mode of transmission, we know fecal-oral route is the mode of transmission. Let us see what details are given here. The major route of transmission is by the contaminated water, food, or by the contaminated milk. The parenteral route also is possible, which is very rarely found, by the blood products or the blood transfusion, or by the skin penetration through the contaminated needles. Then we also have the sexual transmission of HAV. As a sexually transmitted infection, the hepatitis A may occur among the homosexual men. Because of the oral anal contact, it is more commonly seen in the homosexual men. Is it clear? The mode of transmission, we have fecal-oral route, parenteral route rarely, and we have sexual transmission in homosexual men because of oral anal contact. Then we move further to the risk factor. They include the poor hygienic conditions. So by this we know What are the risk factors? We ourselves can state the risk factors. So far we have discussed the multiple risk factors, the poor hygiene and the overcrowding. So the poor hygienic conditions, no proper sewage disposal, the poor sanitation, overcrowding, the contact with the infected person. Okay, the contact with an infected person during the period of infectivity. What is the period of infectivity? 2 weeks prior to jaundice and 1 week thereafter. And then unsafe sex can also result in the sexual transmission of hepatitis A virus, and especially in the homosexual men we see hepatitis A virus, and the consumption of the contaminated food and water, and also traveling to the endemic areas where there is hepatitis A virus infection spread, and then again that will lead to the spread of hepatitis A virus. And the injecting drugs, okay, injecting drugs in the contaminated needles and syringes can also be a risk factor for the spread of hepatitis A virus. And also the lack of safe water, the water which is contaminated with the feces of an infected person. So just in like in rurals where the pond water gets contaminated by the human feces, and if that human feces is containing the hepatitis A virus, then that feces will get contaminated with the water, and that was used for the various purposes, and lack of the safe water will result in the hepatitis A virus. Now, this is the pathophysiology of the hepatitis A. What happens is the virus will attach to the hepatocytes and enters into the hepatocytes. Let me just draw you a liver. What happens is the virus comes and attaches to and then slowly enters into the hepatocytes. And then once it enters into the hepatocytes, inside the hepatocytes, there is viral replication which is occurring in the hepatocytes. Okay, viral replication occurs in hepatocytes. Once there is a virus replication, a body will start an immunological response. The body's immunological response is in the form of immunological markers, and they are demonstrated in the affected hepatocytes. And these markers, immunological markers, you can find them in the affected hepatocytes. Is it clear? What happens? The virus first attaches. Okay, let me draw it in red. The virus first attaches to the liver, then it enters into the hepatocytes. Once it enters into the hepatocytes, it starts replicating. So the virus has replicated, and once the replication is over, what happens? The body's immunological response begins, and because of this response there are certain markers which are seen. In cases of the hepatitis A virus infected persons hepatocytes, we see the markers, that is IgM anti-HAV antibody. So we see that there is a HAV virus and the antibody is generated against this HAV virus. So what is the antibody termed as? What is the name of this antibody? The name of this antibody is IgM anti-HAV antibody. In the serum at the onset of symptoms, also there is a difference between the IgM and IgG. Is it clear? We need to know this. IgM anti-HAV antibody and IgG anti-HAV antibody is seen in the serum. So it is M is seen at the onset of symptoms, whereas G is seen after the subsidence of the acute illness. It gives a lifelong immunity against the reinfection with HIV. It shows that previous infection has occurred. If a person's test is showing IgG anti-HAV, it indicates that a person have had previous infection with HIV. The host immune response. So the host response and the immune response, all of this is leading to inflammation of liver and the damage to the hepatocytes. Is it clear? What happened? The virus entered, multiplied, and this is resulting in an immunological response. This is giving to the development of IgM and IgG antibodies. Okay, anti-HIV IgM antibodies, and then we have IgG antibodies as well. So IgM is seen in cases of an acute illness, and IgG after the subsidence of acute illness when there is a lifelong immunity. What are the clinical features of hepatitis A? The signs and symptoms typically don't appear until you have had the virus for a few weeks at least. The signs and symptoms anyway will include the fatigue, nausea and vomiting, abdominal pain, discomfort, loss of appetite, low grade fever, dark urine. Okay, since the liver is not functioning properly, the bilirubin is excreted in the liver, excreted by the kidneys, and then it is resulting in the dark urine. There is muscle pain, yellowing of the skin, jaundice. Since the bilirubin content is high, we have yellowing of the skin and the eyes, resulting in jaundice, and the clay colored stools are seen. Okay, these are the clinical features. Is it clear? What were the clinical features we saw? Fatigue, nausea, vomiting, abdominal pain and discomfort, loss of appetite. Altogether, you can remember nausea, vomiting, abdominal pain, loss of appetite. Okay, loss of appetite, nausea, vomiting, abdominal pain. Then we have low grade fever. Once low grade fever, then you can remember urine and stools. Dark urine, clay colored or light colored stools. Then we also have muscle pain and fatigue and jaundice lastly. Is it clear? The clinical features, we can group them. What are those? Fatigue, abdominal pain, nausea, vomiting, loss of appetite. Then we have fatigue and muscle pain can be put together. Then we have clay colored stools, dark colored urine. And jaundice is very important, which will be the first sign of any liver disease. And then we will move further to the diagnosis. The demonstration of virus in the feces. So we can demonstrate the virus in the feces of an infected person, in the blood or in the bile with the help of the immunoelectron microscopy. Then we also have the virus isolation. And the detection of antibodies by the help of enzyme-linked immunosorbent assay, and the biochemical tests like alanine aminotransferase where the levels are more than 1000 peaks at 1 month after the exposure. So the ALT levels more than 1000 and it peaks 1 month after the exposure. Is it clear? ALT is increasing 1 month after the exposure to more than 1000 peaks. Bilirubin is elevated leading to hyperbilirubinemia. So we see the bilirubin content is high in the blood. So it is hyperbilirubinemia where the conjugated bilirubin is making the urine dark. Is it clear? This conjugated bilirubin is passed through the urine and it is making it dark. Then we also have the serum protein which will be normal, and the molecular diagnosis is RT-PCR of the feces. Is it clear? Now how does this conjugated bilirubin make the urine dark? Since the conjugated bilirubin is water soluble, it will be excreted through the kidneys. Because of the high quantities of this conjugated bilirubin, that will give the urine a dark color. It is also known as Coca-Cola colored urine or tea colored urine, and this is nothing but the bilirubinemia. Is it clear? I hope you remember now. We can demonstrate the feces we can demonstrate the virus in the feces, in the blood and the bile. We can isolate the virus. We can detect the antibodies, IgG, IgM antibodies with the help of ELISA. And we have biochemical tests like ALT where the peaks are more than 1000 after the 1 month of exposure and the bilirubin is elevated and the urine will be dark colored. Serum protein is normal. Molecular diagnosis is RT-PCR of feces. Moving further to the prognosis. As I said you earlier, it is a self-limiting disease and there is 99% of recovery chances in cases of HIV. Chronic infection does not occur, and the fatality rate is 0.4%. The complications include the fulminant hepatitis. What do you mean by fulminant? Fulminant is nothing but when there is a rapid, massive necrosis of the liver parenchyma and there is a decrease in the liver function, then there is a sudden severe infection, the severe necrosis causing the 80 to 90% the liver function will be damaged. And then we have cholestatic hepatitis, a condition where the flow of the bile from the liver stops. Okay. Then we have relapsing hepatitis. Hepatitis A sometimes can be relapsing, meaning that the person who just recovered will fall sick again with another acute episode of hepatitis A. So these are the complications. What are those? We have fulminant hepatitis, the sudden hepatitis, but it is very severe. Okay, sudden but very severe. And then we have cholestatic hepatitis, cholestatic, where the flow of the bile is stopped, static. Okay. And then we have relapsing, where the person again gets an acute episode of hepatitis A, who was previously recovered, again relapses with hepatitis A. Moving further to the prevention. The best means of reducing the spread of infection is by promoting the simple measures of personal hygiene or the community hygiene. Okay. Along with this, how do we control the reservoir? The control of the reservoir is by the disinfection of the feces and fomites. How do we disinfect them? Use of 0.5% sodium hypochlorite is strongly recommended. As a effective disinfectant, we have 0.5% sodium hypochlorite. Then the control of the transmission, as I said you, by the simple means or the simple measures like frequent hand washing before eating and after using toilet. There should be frequent hand washing, and then we have the maintaining the proper personal hygiene, proper disposal of the excreta, which will prevent the contamination of the water, food or milk. Okay, if the excreta is properly disposed, then we are reducing the chance of the excreta contaminating the water or the food. So once it is disposed of properly, there are less chances of spread of infection or contamination. And the purification of the community water supplies with the help of flocculation, filtration and adequate chlorination. Studies have indicated that 1 mg per liter of free residual chlorine will cause the destruction of virus in 30 minutes at a pH values of 8.5 or less. So we have discussed about the chlorination in a previous sessions. You can check out in the playlist. And we see that 1 mg per liter of the free residual chlorine will cause the destruction in 30 minutes. Once the free residual chlorine, if it is found to be 1 mg per liter, it will destruct the virus in 30 minutes at a pH value of 8.5 or less than that. During epidemics, the boiled water should be advocated for drinking purposes. Okay, since the 5 minutes of rolling boil will destruct the virus, the heating, ultraviolet rays. So we have boiling water should be advocated for the drinking purposes, especially during the epidemics. Then we move forward to the vaccines. There are two types of hepatitis A vaccine which are currently used worldwide. We have formaldehyde inactivated vaccine, which is not for the infants. And then we also have live attenuated vaccine. Let us begin with inactivated vaccine. What are the two? We have inactivated vaccine, and the other one is live attenuated vaccine. Inactivated vaccine is a killed vaccine or an inactivated vaccine. And this vaccine is given at the interval of first it is the administration is 1 ml for adults and 0.5 ml for children, and the dose of administration is 2 doses, especially it is given IM on the deltoid. 2 doses are given 4 to 6 weeks apart, and the booster dose is 6 to 12 months apart. So we see that the complete vaccination schedule is consisting of 2 doses. 2 dose administration, especially in the deltoid muscle. It is IM given to the deltoid muscle. The interval between the primary dose and the secondary booster dose is usually 6 to 12 months. Following the 2 doses of vaccine, the protective efficiency is 94%. So if these two vaccines are carried out, that is the primary dose and the secondary dose, the primary dose between 4 to 6 weeks apart, and then primary and secondary dose should be 4 to 6 weeks apart, and the interval between these 2 doses is 6 months or the 12 months. Okay, let me just write it down. First dose, second dose, interval between these 2 doses can be 6 months or 12 months, and these 2 doses are given, 2 doses are given on the deltoid muscle IM. And these vaccines will give 94% of efficiency if they are administered properly, and for 15 to 20 years immunity is provided by them. Then we will move forward to the live vaccination. Live attenuated vaccine comes as a single dose, freeze dried. Okay, it is a freeze dried vaccine powder. It is reconstituted with the distilled water, and 0.5 ml is administered on the deltoid area or the subcutaneous area. So we see that reconstitution is done. What do you mean by reconstitution? The lyophilized is nothing but the freeze-dried vaccine powder is given in one vial, and this freeze-dried powder of that vaccine powder, it will be mixed with the diluent in another, and this is nothing but reconstitution. It is done with the help of the distilled water. The live vaccine is given in a powder form in a vial, and it is reconstituted with the distilled water. The live attenuated vaccine is administered 0.5 ml on a deltoid area, or a single subcutaneous dose is given. No booster doses are required. The first dose, okay, the inactivated vaccine wanted 2 doses. The primary dose and the secondary dose 6 months to 12 months apart. Whereas here there is only one single dose and there is no booster dose present. The live vaccine is used for both pre and post exposure prophylaxis within 15 days. Post exposure within 15 days it can be, if it is used, it can found to be effective, but the role of post exposure is still uncertain. Then the other treatment aspect, we have human immunoglobulin. The protective efficacy of the immunoglobulin against the HIV infection is well documented. So we see that the immunoglobulins, the efficiency is well documented. The duration of protection is, however, limited to 1 to 2 months. If a patient takes a prophylaxis for HIV, the protection is just approximately for 1 to 2 months, and 3 to 5 months following the administration of IgG at a dose of 0.02 and 0.06 ml per kg body weight respectively. So we see that they give a protection for 1 or 2 months. No, they give us a protection only for a variable period. However, it is limited to approximately 1 or 2 months, and it can be 3 to 5 months following the administration of IgG dose of 0.2 and 0.6 ml per kg body weight. Prophylaxis is achieved within hours of infection and within hours of injection, and is 80 to 90% effective when it is administered before or no later than 14 days of exposure. Even the prophylaxis, what is the drawback? That it has to be given within 14 days after the exposure. It should not be given after 14 days. It has to be given within the 14 days of exposure. Then it is found to be 80 to 90% effective when it is administered before the completion of 14 days of exposure. Moving further to the management aspect, the patient should be advised to take adequate rest and the supportive care. The proper diet a proper diet for hepatitis A will include the small frequent feedings of a high calorie but a low fat diet. The high calories should be rich in carbohydrates so that there's no much fatty intake and much pressure on the liver to carry out the functions. So more of the carbohydrates are recommended. High calories but low fat diet, avoiding or modifying the risk factors like improving the sanitary conditions, moving out of the overcrowded places, stopping the use of syringes. So avoiding, and mainly it is a fecal route rather than the parenteral sexual contact. It is mainly the fecal route. So the sanitary conditions and the hygiene has to be improved. And then the lastly, the vaccination. So we have completed about the hepatitis A in this session. In the next section, we will first continue with A, C, D, and E, and the last session will be about the hepatitis B. With this, we come to an end of the video. If you like the session, hit the like button and subscribe.